Okay, so my task was to review current treatment, and the plan was really I was going to focus solely on sort of the nerve treatment, but I think it's probably important for us to review everything. And so I thought we'd start with anatomy, review the mechanism of injury, review terminology like rupture versus avulsion, review injury patterns, probably review some more anatomy, and then talk about treatment decisions, including manipulating the shoulder and putting it into a better position, using Botox and casting, and then talk about primary nerve surgery. And Dan is going to talk mostly about the secondary surgeries. I think, this slide from the Mayo Clinic is quite nice because if you look at the left side, it really shows in a simplified fashion what's going on with the brachial plexus. So, the upper portion of the brachial plexus controls shoulder function. The middle portion, or the mid-upper portion, also controls, so the upper portion controls shoulder abduction, elbow flexion. The middle portion does mostly elbow extension, and then the lower portion controls hand function, with sensory feedback also coming from those respective areas in a slightly different pattern. I thought, in keeping it as simple as possible, the brain connects to the spinal cord, and then through nerves, those signals are sent to the muscles, and sensory feedback is sent back to the brain through those same nerves. The nerves look like this. This is a cartoon of the nerve. And then you can see under the microscope, there's actually, specialized microanatomy of the nerve. But it's not unlike the conduit or the Romex that's running through many of our homes, in the sense that it's got a specialized sort of anatomy that includes insulation and the ability to essentially conduct electricity. Anatomically, this is the brachial plexus. You can see the lung has been removed here, but all of these nerves contribute to the brachial plexus, and then ultimately turn into the terminal branches of the plexus and give signal to muscles and sensory feedback ultimately to the brain. This I don't know where I was given this slide by Michael Galvez, who's a hand surgeon, a pediatric hand surgeon in California. And this is obviously not how the baby sits inside. But the mechanism is probably something like this. There is traction. It's essentially a traction injury. There's stretch that's placed on the nerves in a downward and lateral fashion during the birthing process. And this results in injury to the nerves. The incidence, as many of you know, is 1 to 3 in 1,000 births, and the risk factors, most notably, are the shoulder getting stuck, a birth weight greater than 4.5 kilograms, and then the others that are listed here. And when we look, if this is, you're going to see various versions of this cartoon throughout my talk, because I think that this really sort of describes what the problem is. So low energy stretch leads to just a stretch injury, and this can often recover all by itself. And what we see in the patients is often a temporary paralysis that gets better. Higher energy injuries result in a rupture of the nerve itself, or a tear of the nerve itself, and avulsion injuries are an actual almost ripping out of the nerve from the spinal cord. And we'll talk again about this, but when you have an avulsion injury, those nerves cannot be repaired directly. This is how we talk to each other, how the surgeons, peripheral nerve surgeons, talk to each other about nerve injury, and we use fancy words that make it complicated for the patients to understand. But basically, a nerve that's been stretched it's called a neuropraxic injury, a neuropraxia. A nerve that's stretched so much that the wire inside it has torn and needs to be reconstructed by the nerve is called axonotmesis. That the axon is the wire within the nerve that transmits the signal, and it can either recover itself or we can help fix it. And neurotmesis is a nerve that's been divided, that's been completely cut. And again, this is another cartoon of the same thing I was just talking about. Stretch injuries can sometimes recover spontaneously. Rupture injuries can be repaired or reconstructed. And avulsion injuries, those injuries of the spinal nerve that have been torn from the spinal cord, cannot be repaired directly, and we need to get the signal from somewhere else usually. This is another anatomy picture from the same textbook that I was showing you before. And this is the spinal cord. This is the ventral part, or the anterior part, and that carries the motor signal. And this is the dorsal part, the posterior part, and that carries the sensory signals. And they come together within the spinal nerve. And I'll show you, this is a cross section. So we're looking at, this is the spinal cord here. These are the rootlets that I just showed you on that previous slide. And those rootlets, the anterior rootlets correspond to motor signal. The posterior or dorsal rootlets correspond to the sensory signal. And then this is the spinal nerve as it's leaving through what's called the foramen, or the opening in the vertebra. And so for us as peripheral nerve surgeons, we can get to these areas that are green in between the, right here, in between the vertebra or the ribs, but we can't get here. We can't get into the spinal cord. And even if we could, it doesn't work. Once that nerve has been avulsed from the spinal cord, it can't be put back in successfully. This is a somewhat more complex cartoon of the same thing I just told you about. And then here's some of the nuance of this. So when it comes to root injury or avulsion injuries, we can sometimes see a root that has been completely avulsed or partially avulsed. The rootlets, those things that I was just telling you about, the anterior ones corresponding to motor, the posterior ones corresponding to sensory, they can be partially torn from the spinal cord. And that many of you have probably heard the term a pseudomeningocele, and that just corresponds to the lining, and that was seen in this previous slide. This is the lining of the spinal cord called the dura, and when it tears, a balloon develops called a pseudomeningocele. And so even if there's a pseudomeningocele sometimes that might be seen on an MRI, there may be still connection of some of those rootlets to the spinal cord. We talk a little bit, I thought it might be worthwhile to talk a little bit about imaging. We will oftentimes see patients who present already having had x-rays, particularly of the clavicle. And it's not, treatment of clavicle fractures is typically conservative. It doesn't require surgical intervention, even in the adult patients. And x-ray of the chest is often utilized to assess the diaphragm position and how well the diaphragm's working. Ultrasound is sometimes used for this as well. And then we'll talk, I have one more slide to show you about imaging. And what we see here, what I was just telling you about, those pseudomeningoceles, are seen on this MRI here. And this is the corresponding axial view. You can see it in this slide as well. So those anterior and posterior rootlets, as we move through the spinal cord, we can see the anterior rootlets, posterior rootlets, and they end up coursing into a spinal nerve. When there's a pseudomeningocele, sometimes we will see the rootlets there, and sometimes we won't. The utility of MRI for brachial plexus birth injuries has been disputed by some. It usually requires general anesthesia to get a good study. It does provide additional information in my practice for surgical planning. And I think, it really helps us evaluate nerve root continuity, the things that we can't see intraoperatively. And it allows also for simultaneous evaluation of shoulder anatomy. Here you see the scapula, what's called the glenoid, and the humeral head. And we'll talk about this in a bit, but really in upper trunk injuries, the more common injuries, this is the joint we're most worried about. And in general, if I'm ordering an MRI, it's after 3 months of age, and it's usually for surgical planning purposes. So it's really important, I think, that patients with brachial plexus birth injuries are seen early and seen on a regular basis. The purpose of this is to assess the progression and hopeful improvement over time, and then determine the treatment plan. And again, we start assessment early. It's usually monthly in my practice. Stretch injuries, as we mentioned already, usually resolve within 2 months. Injuries in which the lining of the nerve is intact, but the axon's been injured, usually improved by 6 months. And nerve injuries, the actual neurotmesis, or the nerve torn or rupture injuries, They will improve marginally or not at all by 6 months. Avulsion injuries usually show no improvement. And this is that was a gross generalization, but the specific root that may have been avulsed, if it's been completely avulsed, will not show improvement. This is a scale that was developed in Toronto for measuring function within the affected extremity. And we don't need to get into the specifics of it, but what's important to know is that what we're measuring as many functions in the arm as possible and trying to be as specific and objective as we can. And it's difficult sometimes in infants to get that data. Sometimes we rely upon you as the family to help give us video or report of how our patients are doing. Treatment decisions typically depend upon the degree of injury. Upper trunk injuries, Erb's palsies, as we call them, are the most common, in some series up to 90%. And these are ones that involve the upper trunk. You'll see a video and some more graphic depiction of upper trunk injuries. Extended upper trunk injuries refer to those that include the middle trunk and involve the weakness of elbow extension and wrist extension. Global injuries are injuries that involve the entire brachial plexus, and we usually, in those cases, do not see good hand function. So just, again, distinguishing upper from extended upper is the presence of wrist extension, is the absence of wrist extension, with the presence of wrist extension being in those more upper injuries. You're going to see this slide again, so you don't need to write anything down. And here is a patient with an upper injury. As they get older, over the coming months, we anticipate spontaneous recovery in most of these patients, and so it's hard to catch them before and many of them have started to demonstrate recovery on their own. And this is a slightly older child with an extended upper trunk injury, and as you see, she has weakness with respect to wrist extension. And then global injuries in which the entire upper extremity is involved. The prototypical posturing of the shoulder seen in upper trunk injuries with internal rotation of the shoulder and extension of the elbow is not often seen, but does sometimes show up in global injuries. But the key is that they have hand involvement. And then in Narakis's classification, he also included Horner's sign, and that is a closing or a not complete opening of the eye on the affected side. So with these injuries, it's known that up to in over 80% of patients with upper injuries will see good spontaneous recovery. In those that have an extended injury involving the middle trunk, we'll see spontaneous recovery in about 60%, and then good spontaneous recovery in about 30 to 50% of those who have a total palsy, but with respect to shoulder and elbow, but not necessarily with respect to hand function. And those who have a Horner sign are known to have the worst outcomes with severe deficits throughout the limb. Based on that Toronto algorithm, based on the Toronto scoring scheme, if we look only at elbow flexion, elbow extension, wrist extension, finger extension, thumb extension, we can make some inferences about what the treatment algorithm should be for management. And generally what they've suggested is that if a patient has a global brachial plexus injury, primary nerve operation should be considered early. And by early, that's usually at around 3 months. If they have the more common findings, then the goal is to focus more so on the shoulder and look for and focus on the shoulder. This has been updated recently to include splinting of the shoulder into a position that prevents deformity of the shoulder. And if the patient demonstrates spontaneous recovery over the time that the shoulder is held in position, then it's possible that they may not even need surgery. So the general guidelines for prediction of good spontaneous recovery include initial presentation without hand involvement, recovery, in my practice, recovery of active wrist extension by 3 months, and then recovery of biceps-mediated elbow flexion by 6 months. And in Toronto, they also developed something called the cookie test, which many of you may or may not be familiar with, which helps to determine whether nerve surgery is likely to help this patient get an outcome which would be better than they would get if they were allowed to go on to spontaneous recovery alone. So concern about the shoulder joint is not news. It's been known since the early 1900s that the shoulder joint is affected in patients that have, in particular, upper trunk injuries. And it's an imbalance of forces, what we think is an imbalance of forces, where the shoulder's held in internal rotation while it's growing, and leads to a this can lead to a deformity of the shoulder joint over time. It's interesting that this is seen only in brachial plexus birth injuries and not in adult brachial plexus injuries. It has to do with the fact that the shoulder joint is trying to grow during the time that it's being held in this abnormal position. So early treatment generally includes therapy, assessment of motor function, assessment of progress, and institution of protocols and splints to prevent contractures. And here are two of the patients in my practice with two different types of splints that help prevent glenohumeral deformity or deformity of the shoulder joint. We can add botulinum toxin, and this was well described. This has now been 13 years since this paper was published out of Texas, indicating that at the very least we're buying time, and I think in many cases we're avoiding shoulder surgery altogether for some patients who would have otherwise gone on to recovery of external rotation on their own. This was more or less confirmed recently at the most recent Neurocus meeting in Berlin in 2022 from the group from Finland, showing that when they instituted their Helsinki protocol, and it was initiated in around 2010, that the number, and it included early passive exercises, ultrasound screening of the shoulder to ensure that it's reduced, botulinum toxin injections, and splinting, like you see in this baby here, as well as targeted surgeries to improve those muscles that do external rotation. And what they showed over time is, if you look here, red is relocation of the shoulder, gray is subscapularis lengthening to help improve shoulder position, yellow is tendon transfers. And what you see is after the institution of their protocol, they hardly needed to do any of these shoulder surgeries on their patient population. It decreased from 28 to 7%. So it's a lot of information. I think to just review and simplify that the most common patterns of presentation include upper trunk or extended upper trunk injuries, and these tend to have the best prognosis and it's the most frequent presentation, versus global or total palsies, in which the hand is involved, and this is the most challenging from the surgical standpoint. The decision to proceed with surgery for these patients is pretty much accepted by most peripheral nerve and brachial plexus surgeons, that if there's no recovery by 3 months of age, that surgical intervention for patients with global injuries is warranted. If there's a persistent upper trunk injury, then timing is a bit more controversial. And so if you talk to Professor Gilbert, depending upon when you talk to him, he'd say an absence of biceps-mediated elbow flexion by 3 to 6 months is an indication that that patient would benefit from nerve surgery to improve shoulder function. The biceps is just a surrogate measure of what the shoulder is going to end up doing on its own. Howard Clark from Toronto reports that in general they wait a bit longer and will perform a cookie test at 9 months of age. Peter Waters from Boston, or now from North Carolina, has suggested that no biceps mediated elbow function or flexion by 5 months is an indication. And then Jörg Baum from Germany has suggested that an absence of no shoulder external rotation by 10 months is an indication to intervene. So how do we deal with nerve gaps? These are options for managing nerve gaps and nerve injuries when we do actually operate on nerves. And most important is that this is, in my opinion, autograft nerve that comes from typically a sensory nerve from somewhere else on the body is really the gold standard for management. Grafts are used when the two ends of the nerve cannot be put back together. And these types of injuries, these stretch injuries, are not like a sharp injury. The area of damage to the nerve is quite large and long, And what we oftentimes find is that it's almost impossible to get those two ends of the nerve back together. So nerve grafts come from generally from the back of the leg. The most commonly used nerve grafts are the sural nerve graft from the back of the leg. It provides sensation to a small area on the lateral aspect of the foot. In infants, we can generally harvest about 10 to 13 centimeters. And then there are other sensory nerves within the arm that can be used, as well as the neck. The cervical plexus of the neck provides sensory nerves for nerve graft material. This is a cartoon and an actual picture depiction of a brachial plexus injury. What you see here is an injury to the nerve coming from the roots so that the head is up here, the chest would be over here, the arms way over here, and you're seeing the upper trunk, the anterior and posterior divisions of the upper trunk and the suprascapular nerve, and it corresponds to what you're seeing in this picture here. So treatment can include neurolysis, though the current paradigm is largely to excise badly scarred nerve and then replace it with nerve grafts, or to perform transfers from a signal that's redundant in a nearby nerve. The goal really in the upper trunk injuries is to prevent problems like this from developing, this is a posterior dislocation of the humeral head and a poorly developed glenoid as a result of persistent internal rotation. So when thinking about surgery, like I've already mentioned, and when we perform surgery, we'll often add Botox to the plan to help counteract the imbalance across the shoulder joint and place the patient into a cast like this to prevent the development of this complication or sequela. These are cartoons from Dr. Narakis from a chapter that he published in 1980s, but the paradigm hasn't changed much, and the goal is to basically take signal from good roots and put it into area that needs signal. Within the past 20 to 30 years, the suprascapular nerve to spinal accessory to suprascapular nerve transfer has gained a significant amount of popularity. And this just involves taking signal from the trapezius, the muscle that does shoulder shrug, and giving it to the nerve that does external rotation. There are some groups that have shown that nerve transfer alone for treatment of upper trunk injuries, and that nerve transfer includes the spinal accessory to suprascapular nerve, a radial nerve, the nerve that supplies the triceps being transferred to the axillary, and the ulnar nerve being transferred to the biceps, can show as good or better outcomes. So our goals are for upper trunk injury to improve shoulder and elbow function, and for global injury, our main goal is really to restore hand function #1. And this is from Kristen Davidge. This is a nice table from Kristen Davidge out of Toronto showing that, what our goals and expectations for brachial plexus injuries in newborns and children are really focused on, for the global injuries, are focused on the hand, more so than the elbow and shoulder. And in adults, the elbow and shoulder. And we can get into the reasons for this, but it's largely related to the ability of those muscles to recover depending upon how far they are from their signal or the signal that's being brought to them. So nerve reconstruction, nerve graft reconstruction of global and total brachial plexus injuries has included, so what we're seeing here is C5 and C6 roots are intact, C7 and C8 have been avulsed, and signals being given from C6 to the middle trunk as well as the lower trunk here, with maintenance of the T1 contribution to the lower trunk. This shows another depiction of a patient or a reconstruction using nerve grafts where C5 is giving signal to the upper trunk. So C5 and C6 are giving signal to the upper trunk. C7 is giving signal to the middle trunk and to the lower trunk as well. Donors for nerve transfer in global cases include the spinal accessory nerve, the intercostal nerves, and the contralateral C7. And here is, this is intercostal nerves. This is a cartoon demonstrating transfer of intercostal nerves for elbow flexion. And here's transfer of intercostal nerves for elbow extension. This is the contralateral C7 cartoon showing signal taken from the contralateral C7 and being given to, in this case, the upper trunk, and in this case, the lower trunk. This is really reserved for patients in which no or only one root remains attached on the injured side. So, I think it's important also to ensure that wherever you go for treatment, that the composition of your team includes, at the very least, a surgeon and a therapist that are trained in the care of brachial plexus injuries. It's helpful to also have a neurologist and/or a physiatrist, as well as a navigator and a coordinator. And in my opinion, a psychologist is really invaluable in helping to take care of these patients. This is actually from our recent Christmas party in my house, and the majority of the people pictured here are actually our pediatric hand therapists and occupational therapists that help take care of the brachial plexus patients. So in summary, I think early referral to a brachial plexus center is important, and I think you should expect and demand multimodal treatment and multidisciplinary management that includes a skilled therapist. I think, really important here are your board of directors, who have been really, they have made themselves present at every important meeting and are really uncovering the, in my opinion, those areas that are really in the gray zone as far as what to do for the management of these injuries. Thanks.